Great, good morning, everyone, and welcome to our webinar this morning, sponsored by the Northwest Mental Health Technology Transfer Center. We're delighted that everyone has joined us this morning, and I know people are still signing in, but we'll go ahead and get started in the interest of time. And very delighted to have everyone joining us today for a really wonderful talk by Dr. Pamela Collins. There's some information on this introductory slide that may answer a lot of your questions, but we'll go through those right now before Dr. Collins gets started. So on behalf of the Northwest Mental Health Technology Transfer Center, I'd like to welcome you to today's webinar, which is Reducing Racial and Ethnic Disparities in Mental Health Care Through Practice and Policy. And our presenter today is Dr. Pamela Collins. We're very grateful that so many of you can join us to learn more about this important topic, and we look forward to sharing information and guidance and to having an exchange of information with all of you. My name is Lydia Chwastiak. I am a psychiatrist at the University of Washington and a professor in the Department of Psychiatry at UW. I'm also one of the co-directors of the Northwest MHTTC. And I want to just tell everyone a little bit about the MHTTC for those of you that are new to us. The Mental Health Technology Transfer Center Network is a national network of training and technical assistance centers that's funded by SAMHSA. And our purpose is to support the behavioral health workforce to disseminate and implement evidence-based practices for the treatment of mental disorders. And some of our other goals are to heighten the awareness, knowledge, and skills of the behavioral health workforce, to foster regional and national alliances, and to provide free training and technical assistance related to the care for treatment of mental disorders. Specifically about our Northwest Mental Health Technology Transfer Center, we're based at the University of Washington in the Department of Psychiatry, and we provide training and technical assistance to HHS Region 10, which includes the states of Alaska, Idaho, Oregon, and Washington. And we have a primary focus of our training and technical assistance activities on evidence-based practices for serious mental illnesses such as psychosis. But we also provide training in a variety of other topics, including suicide prevention, school mental health-based services, peer support services, trauma-informed care, and integrated care, which is the focus of my work. And this webinar this morning is actually one of a series of 3 webinars that relates to addressing disparities in access to mental health services through integrated care. So we'll tell you a little bit more about this at the end of Dr. Collins's presentation. Our target workforce includes any providers whose work has the potential to improve behavioral health outcomes for individuals with or at risk of developing serious mental illness. So this includes behavioral health providers and staff, primary care providers and staff at schools and community organizations. I do want to say a few words about language. Before we get started, it's our intention to always be mindful to use language that promotes recovery and that is culturally appropriate. So we encourage all of you to use language that demonstrates respect for a person's dignity and worth. This is consistent with recovery-oriented practices and promotes treatment environments that foster respect, dignity, and hope. So just a couple of words before I turn it over to Dr. Collins, a couple of words about housekeeping. We've made every attempt to make today's presentation secure. If we need to end the presentation unexpectedly, this happens. It has happened, fortunately it's not happened to us, but has happened in Zoom webinars. We will follow up with you using your registration information. So just know that. We're a large audience today, so all attendees are muted and will not appear on video. So please use the Q&A. If you have questions for Dr. Collins, please use the Q&A to ask questions for her, and I will moderate those. I'll curate those and ask those at the end of the session. Please just be careful if you do have a question not to use identifying information about a person who receives services if you do share a question. Presentation is being recorded. The recording and the slides will be made available on our website in a few weeks, and you'll be notified by email when it's available. And we will provide certificates for attendance at this webinar, but there are no formal CEUs available. We will, at the end of the session, near the end of the session, chat a link to a brief survey, a brief evaluation survey that is required by SAMHSA, so we can continue to provide free trainings. This feedback is really critical to our work, so we'd appreciate you taking the 3 or 4 minutes to complete this very short survey. So that'll be in the chat box at the end of the session, and our team will follow up with you by email tomorrow if you don't have time to do it today. So again, asking questions should go in the Q&A box. I'll be monitoring the Q&A box to facilitate Dr. Collins answering as many questions as possible at the end of the presentation. Please don't put content questions in the chat box because we can't copy those into the Q&A box. So content questions should go in the Q&A box. And if we can provide a short written question during the webinar, or Dr. Collins will get to as many questions as she can at the end. Chat box is for technical issues, and our team will respond to any technical issues. So that's what the chat is. Okay, so just a brief disclaimer. We are acknowledging that we're funded by SAMHSA. We're very grateful for their support. And so SAMHSA is bringing this webinar for you this morning, but all the comments today are Dr. Collins and don't reflect and they don't reflect an official position of SAMHSA. Okay, so now I'm delighted to present today's speaker. She is a really wonderful colleague within the Department of Psychiatry. Dr. Pamela Collins is a professor in our Department of Psychiatry and also in the Department of Global Health at the University of Washington, where she directs the Global Mental Health Program. She's a psychiatrist and a mixed methods researcher with 25 years of experience in global mental health research and global public health research and policy work, and has done really outstanding work throughout the world in education, training, and capacity building and policy leadership. So I will turn it over to Dr. Collins to begin the presentation.
Good morning, everyone. It's really nice to be here. Lydia, thank you so much for that introduction. And I wanted to just start by, and people can put this in the chat, to just get a sense of who's in the audience. Can you tell us if you are a clinician, if you are somebody that's involved in decision-making around service delivery? Are you a policymaker? Are you a researcher? Would love to get a sense of who's here. Okay, we have case managers, we have clinicians, peer support specialists, counselors. Okay, a lot of health educator, clinicians. Here we got some administrators as well. We have counselors, administrators. So we have a nice mix of program administrator, a lot of clinicians, prevention specialists, recovery guides. Okay, that's great, policy and clinician. So we've got a good mix. So it looks like we're mostly clinicians, administrators, and some folks have some policy related roles as well. That's great. So I'm gonna start by sharing my screen. And once I share my screen, I'm gonna turn my video off while I'm presenting, and then I'll come back on video a bit later so that I can get started. Okay, so I want to talk about reducing racial and ethnic disparities in mental health care through policy and practice. And I'll start with a definition of disparities, and there's more than one definition of what disparities are. So a health status disparity has been defined as any equality in health due to social factors or allocation of resources that is unjust. So it's really about unfairness with that definition. Healthcare disparities have also been defined as any difference in healthcare quality that's not due to differences in healthcare needs or preferences. Which I think importantly raises this issue of preference. What is it that people want? And are your preferences influencing how you make decisions about seeking care or remaining in care. And this is what this looks like graphically. If we look at non-minority populations and minority populations, and you see quality of care on the y-axis, with increasing quality of care as the bar gets taller, that gap in the experience of quality of care could be related to several things. It could be related to the clinical appropriateness and the need, as well as patient preferences, which we just mentioned. It can also be related to the operation of the healthcare system and the legal and regulatory climate in the healthcare system. It can also be related to discrimination and experiences of bias, stereotyping, or uncertainty in that environment. And these, the latter two are domains that influence disparities, because these are domains where we can see the operation of unjust systems, institutional inequalities, as well as outright discrimination on a personal level. And I'll say more about that in a minute. So one of the ways in which we would try and understand disparities would be to compare, let's take an example. This is an example. This is actually SAMHSA data from the NISDA survey, which is showing us trends in the prevalence of serious mental illness in the past year among adults in the United States from 2008 to 2019. And these different bars are representing age groups, with the clear ones at the bottom representing people over the age of 50. The triangles are people from 26 to 49. The blue squares are 18 to 25. And then the diamonds overall, that gold colored diamond represents all adults, so everyone 18 and older. The takeaway from this slide is that the percentage of people with severe mental illness in the United States, if you follow that gold line, increased from 3.7% to 5.2% from 2008 to 2019. So that gives us a picture of the entire United States, and then we get this picture of what these prevalence estimates look like for people of different ages. I just have to make my slide advance, okay. And here are those data, again broken out by age, but looking specifically at African Americans. And if we look at this blue bar in the middle is all adults, all African American adults, and you can see that essentially the takeaway from this slide is that the percentage of people with severe mental illness who are adults began at around 2.5% in this group and ended at about 4%. So a little bit lower than the prevalence rates for the general population. But let's go to the right-hand side. And this is where we need more data to understand what we're seeing here. Are we seeing differences? Are we seeing disparities? Or are we seeing the same rates of treatment as the general population? Because what this column on the right is telling us that only 35% of African American young adults with severe mental illness actually received treatment in 2019. So 65% got no treatment, and that 58% of African American adults from 26 to 49 with severe mental illness received treatment. So about 42% received no treatment. These numbers are not encouraging. But we need more data to really be able to compare this group to other groups in the United States to determine whether or not there's a disparity. And I raise this here because I'll be presenting some data later on that teaches us something about how members of diverse racial and ethnic groups in the United States access mental health services. But some of our studies enable us to actually determine whether a particular intervention is effective in reducing an actual disparity but others really simply inform us about how people seek services, what can influence whether a group of people seek services, but they don't give us the data to make those comparisons. And that's okay. It just depends on what we need the data for and how we're using those data to make decisions about care or decisions about policies. These are older data from SAMHSA that are provided by AHRQ, another US government agency for health services. And the reason I'm showing these, even though they're a bit older, is because they actually do show you what this comparison looks like side by side. So this is data showing us adults with a major depressive episode in the past year who received treatment for depression in the past year by race. And this was from 2008 to 2013. And here it's a bit clearer where the differences are, right? So we're seeing the black bar represents the total. And we can see those numbers. So, you know, it's about 70% of all adults in 2008, and still looks like it's about the same at 2013. About 70% are receiving treatment for depression if they needed it in the past year. But this green bar and the blue bar represents white adults, and the green bar represents Black adults. And here you can see that there is a distinct difference, that in fact, among Black adults from 2008 to 2013, fewer than 60%, I'm guessing that's a guesstimate of about 55%, were receiving depression care. And by 2018, that number is just at 60% compared to around 70% for the national and the white average. We'll take one more look at adolescents with a major depressive episode in the past year who received treatment for depression. And looking at these data by race, again, the black line in the middle represents the total, and the green lines represent whites, and the blue represents whites, and the green, which is this bottom line, represents Blacks. Or we can go by squares. Squares represent the white population, and triangles represent the Black population that was sampled in this particular survey. And here again, we see this distinct difference. Now, we also see that the totals are not that good, right? We're seeing that under 40% of adolescents with a major depressive episode actually received care between 2018 and 2013. And similarly, among white adolescents, that number is just over 40%, and it ends about the same at just over 40% actually receiving treatment. But again, when we look at the data among Black adolescents, that number is much lower. So it's just above 30% in 2018, and it pretty much stays the same. It's actually, it goes up, but then drops back down by 2013, and it's right at 30%. So here's a difference. And our question would be, how do we understand what is accounting for those differences? And would we assume that these differences are in some part have something to do with disparities in our system? And the safe assumption is probably yes. And I say that that assumption is safe, given the number of factors, social determinants in our environment that influence how and why and where people are able to access mental health care. I'm going to say a word more broadly about discrimination as a driver of health disparities. Certainly one key driver of health disparities is socioeconomic status. That's a strong predictor. But importantly, disparities by race persist at every level of socioeconomic status. So if we were to look at those data on mental health care access, it may not matter as much how people are distributed by socioeconomic status. There certainly will be some differences, but I think that the importance of this study, this is a review that David Williams and his colleagues presented. It's really telling us that when we think about health disparities, we need to think about discrimination. We need to think about racial disparities in particular. And I want to spend a few minutes talking about race and health inequities. And Williams and colleagues would say that racism and health inequities operate by three main pathways: cultural racism, institutional or structural racism, and individual level racism. And this is another way to examine these different forces. So this is the house that racism built. And cultural racism represents stereotypes, stigma, and biases. Institutional racism represents those kinds of acts of racism that are built in to the way that we work, that are built into policies that are often legislated. Segregation is a good example of that. And then individual racism really has to do with the interpersonal interactions that people experience. And all of these have influences on many domains of life. They have influences on income, they have influences on education, they have influences on employment and access to employment, they have influences on housing access, wealth, health, incarceration, stress, as well as individual and collective resources and social resources. And all of these have influences on institutional racism and how it plays out. They have influences on the experiences of individual race discrimination, which ultimately have mental health consequences at the individual level. But I think it's important to recognize that the takeaway is that these are systems. Racism, as you can see from the left column, is a societal system, and it works through social forces at multiple levels, at political levels, legal levels, economic, religious, cultural, and of course, this is a part of our history, and we can understand this clearly through historical events. So recognize that when we're talking about disparities, when we want to parse them, try and understand how they originate in the United States, particularly in the context of examining disparities related to race and ethnicity, we need to understand the complexity of social determinants, of which discrimination and racism are very important. And these are complex, multi-level exposures that have an influence on people's lives at the individual level, but also at the social level, and certainly in the context of the healthcare system. And I'll just mention the right-hand column, which is giving you an example of what happens, how discrimination actually influences mental health for individuals. We know that discrimination is associated with poor mental health, with depression, anxiety, and psychological stress, with negative emotions, with declines in trusting, with declines in conscientiousness in some settings. And we know that there are protective factors against the harms of discrimination. And these include religious beliefs, where there is some evidence, as well as behavioral and emotional support. So religious beliefs and practices, as well as emotional support and social support, can be really strong protective factors. There's also some evidence that racial identity is another protective factor, that having a strong racial identity can be a protective factor against the ills of discrimination. And when we think about how people experience discrimination, I want to also point out that in addition to the structural discrimination that we saw in the house that racism built, there are also the very subtle insults that people experience on an ongoing basis. Chester Pierce was an African-American psychiatrist at Harvard who actually coined the term microaggression. And I think many of you have probably heard this term. And microaggressions are subtle insults. They can be verbal, nonverbal, or visual, that are directed toward people of color, often automatically or unconsciously. And what Chester Pierce referred to these. When he talked about these, he said these were these subtle forms of racism that have dramatic impact on the lives of African Americans in particular. He was really focusing on African Americans. And he emphasized that these are often used against people and presumed to be innocuous, but that there's a cumulative weight of this never-ending burden of exposure to these kinds of insults that are a major ingredient in Black-white interactions. So I bring these to our attention because as we think about, I want us to think about the small things that can happen in a clinical encounter or when someone goes to their service provider, the relatively small things that are subtle that people may not always be aware of, but that people of color who are in those settings, patients of color, clients of color, may experience, and that may contribute to an environment feeling unsafe, unwelcome, etc. Now I want to contrast this very individual experience to population level influences that are also based in racism and discrimination, and that have effects on mental health outcomes. This is a study that Jacob Bohr and his colleagues did to try and understand whether or not police killings of Black Americans have a population level mental health effect. And what they actually studied to see when a police killing of a Black American happens, and this is televised, this is on the news, what happens to people who live in the same state, irrespective of whether you live in the same city or neighborhood. Simply living in the same state, actually, that exposure is actually harmful to mental health outcomes. And what they found, I'll just summarize this briefly, what they found was that Black Americans who were exposed to one or more police killings of unarmed Black Americans in their state of residence in the 3 months prior to the survey, that exposure was associated with an additional percentage of poor mental health days among the residents of those states. And usually the effects on mental health occurred in the first or second month after the exposure. But the important issue was that the cumulative effects of this lead to a significant reduction in population mental health for Black Americans. So when we're thinking about disparities in mental health outcomes, we need to think about both the small things that happen in individual interactions like microaggressions, but we also need to keep in mind the exposures that people have that are in the environment, right? In the environment, including in the news environment, that also have an impact on mental health outcomes. So there are many levels to be concerned about. So I want to take us, give us a little bit of a historical perspective as we think about what has shaped race-based inequities in mental health in the United States. And we'll start in the 19th century, where race has been uniquely intertwined with the mental health system really since its inception. In fact, the enslavement of African American individuals was purported to be a protective factor for their mental health. Some of you may be aware of that. And erroneous reporting in the mid-19th century estimated that the prevalence of mental illnesses among African Americans who resided in free states was more than 10 times that of those residing in states with enslavement. So this kind of propaganda not only argued against abolitionist and emancipation movements, but it also affected local and state government responses, as well as philanthropic support that was needed to apply resources for the care of people with mental illnesses. And these trends really continued after the Civil War, Emancipation, and Reconstruction periods. As certainly as you know, segregation pervaded the mental health services landscape. And local municipalities and state governments provided custodial care and treatment of African American individuals in separate institutions or wards. And this care was typically not accessible, scant, and of poor quality. And African Americans, of course, were not the only people to experience this kind of poor quality of care. For Native American individuals, a segregated healthcare system also existed. And despite a federal trust relationship that was intended to deliver particular services to meet the needs of American Indians, specifically through the Bureau of Indian Affairs, these services were incredibly underfunded, under-resourced. And in the 1920s, there was only one hospital in existence for the treatment of Native American individuals with mental illnesses. So our policy history doesn't start out very well. Oops, just hang on, let me just get back into the slideshow. Sorry about that. Okay, are you seeing slideshow? Lydia, can you tell me?
We're seeing your PowerPoint with the slides on the column to the left. There you go. That's slideshow. Yep.
Get back to where we were. I have no idea why this is doing this. Hang on. Sorry about that. Okay. So that as we move into the 20th century, we actually begin to see some improvement. So the 20th century ushered in a response to mental health care and a confluence of social policies that advanced ideals of equality. In 1946, the National Mental Health Act was signed into law, and it served as an answer to strained public health services and resources after World War II. However, this did not ensure equity and access to care. In 1963, this Mental Retardation Facilities and Community Mental Health Centers Construction Act actually legislates community health centers, but because care was assigned by catchment areas, this in and of itself contributed to disparities because catchment areas were segregated and people then attended segregated services and received segregated treatments. Now, the 1964 Civil Rights Act prohibited discrimination in federally funded programs, and the 1965 Medicare and Medicaid Act actually desegregated hospitals and healthcare systems. So in the 1960s, there were some very specific policies to address minority mental health. The National Advisory Commission on Civil Disorders, or the Kerner Commission, describes racism as a primary cause of violence in the US, and the Joint Commission on the Mental Health of Children defines racism at the time as the primary public health problem in the US. And mental health providers are listening to this, right? African American psychiatrists are motivated by these reports, these outcomes, to advocate for specific interventions for minority mental health. And at the time, the National Institute of Mental Health establishes the Center for Minority Group Mental Health Programs. And that center is meant to oversee and develop programs of care and services and research for minorities in the United States. In 1980, the Mental Health Systems Act actually leads to the establishment or the appointment of an associate director of minority concerns at NIMH, again, responsible for services and programs for members of minority ethnic groups. In 1985, the Heckler Report from Health and Human Services comes around, and it details the health outcomes of and highlights disparities in health outcomes by race and ethnicity. And this leads to the establishment of the Department of Health and Human Services Office of Minority Health. So those were all policy changes that support increased attention to mental health disparities, and particularly increased attention to racial and ethnic groups that are underattended to more broadly. In 1992, this public law 102-321 establishes the National Institute of Mental Health Associate Director for Special Populations. And the person in this role coordinates research, policy, and programs for women and minority populations. And I have to just say that I joined NIMH in 2009, and I was the Associate Director for Special Populations from 2009 to 2017. In 2001, the 16th Surgeon General's report on mental health care, culture, race, and ethnicity was really a groundbreaking report that outlined the problems for accessing mental health care, receiving equitable health care, determinants of mental health outcomes for members of different race and ethnicity groups in the United States, and specifically outlined a strategy for achieving equity in our healthcare system. And this was followed in 2003 by the Institute of Medicine's Consensus Report on Unequal Treatment. And what was great is that both of these pointed to the need to improve access to quality of care, that we needed to develop a workforce that could actually meet the needs of people seeking care, and we needed to have consumer and community engagement. And just to show you, this is a summary of some of the recommendations that came out of the Surgeon General's report. This was Dr. Dr. David Satcher, and these included expanding the science base. So we needed more research on the epidemiology of mental health problems in diverse communities, as well as evidence on the interventions that work. The report recommended that we needed to improve access to treatment, and I'm just highlighting a few of the sub-bullets, including integrating mental health in primary care, ensuring language access. We needed to reduce barriers to treatment, and that included extending health insurance for the uninsured, improve quality of care by developing, evaluating culturally responsive services, supporting capacity development more broadly, promoting mental health by addressing social adversities and strengthening families. So these were some of the big recommendations, the high-level recommendations from coming out of the Surgeon General's report. And I would say probably one of the most important policy interventions was the Affordable Care Act in 2010. And in 2010, the Mental Health Parity and Addiction Equity Act of 2008 was finally implemented. And so with the Parity Act, more people were more likely to be treated for common mental disorders in primary care, but it wasn't quite that straightforward. Actually, non-Hispanic Black people were less likely to receive care. So while the Affordable Care Act increased access to care and increased access to insurance, as you can see, one of the recommendations of the Surgeon General's report, there's always a complexity in understanding how disparities are reduced. And I'll come back to this in a few minutes. The Affordable Care Act also importantly expanded access, of course, as I mentioned, for members of racial and ethnic minority groups to care more broadly. And other outcomes of the Affordable Care Act, other measures included in the act, were the establishment of the National Institute on Minority Health and Health Disparities at the National Institutes of Health. Previously, it had been a center. It was elevated to an institute. And then most of the agencies in the Department of Health and Human Services opened offices of minority health. This was also part of the Affordable Care Act. So what are some of the drivers of mental health disparities for diverse racial and ethnic groups? I'm going to move us into talking about a study that colleagues of mine and I did when I was at NIMH to try and understand what are the interventions that are most effective in reducing barriers to, or really reducing disparities in access to care, specifically around initiation of care. And this is a systematic review, and I'll take you through what we did and what we learned. But first, we wanted to understand what are some of the drivers of mental health care disparities. We've talked about some of the large environmental and contextual drivers, and others that I'm sure you are also aware of are simply shortages of mental health care professionals. We have enormous shortage areas in the United States for professionals, and many of those affect places where racial and ethnic minority groups live. Culturally divergent beliefs about the causes of mental illness are also a driver. Lack of confidence in the formal mental health system, negative attitudes about psychiatric treatment, limited English proficiency are major drivers. Interestingly, between 2004 and 2012, racial and ethnic disparities in accessing mental health care increased in the United States, mainly because of increased access to psychotropic medication among whites. So that increases the disparity, right? You see the difference. Because highly uninsured rates among members of racial and ethnic minority groups. So we still have people that were not insured by 2012, and then difficulty detecting psychiatric distress among some members of some minority groups. So I highlight this because, again, when we have changes in policies, sometimes an increase in access for another group simply highlights the lack of access for other groups. So when we talk about access to care, we're talking about a complex set of attitudinal, behavioral, and resource-related factors that include availability of care, accessibility of care, affordability, and acceptability of health services, as well as accommodation of services to people's needs. And racial and ethnic disparities exist among both high and low users of mental health services, but much of the disparity that we see for members of racial and ethnic minority groups appears to stem from actual lack of initial access to mental health services. So to better understand this, we reviewed literature from the beginning of PubMed through 2016, and we wanted to look specifically at studies that included racial and ethnic minority groups that lived in the United States, where the study design used an intervention that sought to improve the initiation of mental health care, where the study examined outcomes related to initial access, and these could include new appointments with a mental health care provider or a willingness to initiate medicine or a psychological intervention. And there were 29 studies that we identified in this review. So there were a number of interventions that these studies examined. And one was first cultural adaptation. So 23 of the 29 studies used some form of cultural adaptation. That included incorporating feedback from participants on the intervention itself, hiring culturally and linguistically compatible interventionists, meaning some of those might have been therapists or people who were providing screening for mental health problems, using images and phrases that fit participants' cultural context, and training providers in cultural sensitivity. It also meant meeting practical needs, so ensuring that appointment reminders were sent, transportation access was provided, or modifying the intervention to align with participants' concepts of mental health. And interestingly, 20 of the 22 studies that did not show a reduction in disparities used some varying degree of cultural adaptation. So what this is saying is that cultural adaptation was an important component of most of these interventions, but it was not necessarily a driver for reducing disparities. Policy interventions. One study was about a policy intervention that showed that when Medicare Part D was implemented, and this removed restrictions on the number of reimbursable prescription medications that enrollees could receive, disparities in the receipt of antidepressants between African Americans and whites actually increased in states that removed drug caps. And this again is because of the increased receipt of antidepressants among non-elderly white patients. Another intervention was screening and referral, and 2 studies looked at this, one in which social workers and primary care providers were trained to screen for depression in nursing homes and primary care clinics, and screening did reduce disparities in receiving antidepressants in these particular studies between African Americans and white older adults. Psychoeducation was another intervention that was aimed to educate patients about entering into psychotherapy and attending psychotherapy. It was meant to improve depression or psychosis literacy, to reduce stigma associated with antidepressants, to increase access to help seeking or available mental health resources. And those outcomes were that psychoeducation tend to improve the frequency with which people actually raised concerns about their treatment. It improved their knowledge about depression or psychosis. There was evidence that it reduced stigma associated with using antidepressants, improved attitudes about depression treatment, improved willingness to recommend seeking a professional mental health services. But most of these were not studies that had a comparison group, so they actually could not measure disparities reduction. They didn't have a different ethnic comparison group. Co-location of mental health services was another intervention, and the PRISM study that Pat Ariane here at the University of Washington led was one of those studies. And this compared integrated care to enhanced referral. And what they found with this study was that when you provided assessment, care planning, counseling, case management, all of these things in one setting, for Latinos and African Americans, this group was more likely to actually seek mental health care providers than their control counterparts. There was no change for Caucasians, and actually Asians in the intervention group were less likely to initiate mental health care. Providing telepsychiatry at a community health center also increased mental health appointments and antidepressant use for a group of Latinx patients, and a school-based youth suicide program where school staff were trained as crisis team members improved health seeking from community mental health services. So in this particular study, Latinx students were less likely to seek care from community health services, and there was really no racial or ethnic difference seen in the use of school-based mental health services. So collaborative care. 2 collaborative care trials that you are probably familiar with, the Partners in Care trial, which focused on collaborative care for depression, saw improvements of quality of care for depression, and improved mental health quality of life 2 years after the intervention, and still 5 years later disproportionately among African American and Latinx participants. The Impact study, which was collaborative care for older adults. In this study, African Americans receiving the intervention improved their initiation of psychotherapy. But what we found was that 4 out of 7 collaborative care studies yielded greater initiation of treatment for members of ethnic minority groups compared to usual care. So in summary, 7 of the 29 studies provided evidence of improved outcomes and disparities reduction in initiation. And those were through screening and referral interventions, co-location of primary care mental health services, and collaborative care interventions. And 6 of the 7 that actually reduced disparities used integrated care models. So why might this be? I'd love to hear from you about what you think, but certainly 2 of these issues have to do with practical convenience, also with privacy and seeking care for mental illness. Another thought is that often in collaborative care or in primary care settings, there are many different kinds of providers there who offer services. And so that may also reduce barriers to care. You may have social workers, you may have a nurse, you may have the primary care doctor. Different kinds of providers are able to provide those needed interventions. But there's more to it. Access also involves understanding complex interactions among contexts, illness characteristics and the course of illness, understanding social networks and systems of care. So we still have to understand these multi-level factors that predict disparities, like things at the individual level, the neighborhood level, and the level of policy. Other factors include, for example, being educated, living in an urban area, being female, having a mental and general medical complaint actually predict greater initiation of care. Being Black or Latinx, being publicly insured, not being a citizen, and being healthier predict less initiation of mental health services. So what else can we do to learn more about this? We need to include more voices of people from diverse ethnic groups in these studies. Most of these studies are very much kind of provider driven and focusing on the outcomes that the treatment team measures and not as much on the perspectives from the people who are participating in care. We need more evidence on how multi-level interventions to address disparities can change initiation in care as well as outcomes. And we also need to ensure that clinicians understand why and how systemic racism as one of these environmental influences actually can affect decisions to seek care or avoid care. And I will end there and stop sharing. And I think we have some time for discussion and some time for questions.
We do. Thank you so much, Dr. Collins. This was a fantastic presentation. A lot of information for us to process, and just want to remind everyone that we'll have we'll chat the link to the brief survey that we'd like you to complete. But I'll give people a few minutes to type their questions into the Q&A, because I think there are a lot of you brought up a lot of really interesting issues that I think we're all dealing with as either clinicians or administrators or policymakers. And I think the work at the end is particularly helpful and informative for us, because all of those strategies that you found in your systematic review are things that you know, the people in the audience and have tried, including cultural adaptation and psychoeducation. And so thinking about why co-locating services, why integrating care would have such a powerful effect. I'm, you know, just wondering if people have thoughts, or if you want to say a little bit more about, is it just related to the logistical, you know, addressing some logistic barriers or reducing stigma or increasing privacy? It sounds like there's more kind of complex factors at play related to the system.
Well, and I also think primary care is generally more accessible anyway, right? It actually is more accessible. And one of a major driver of disparities is actually simply not being able to get to a mental health care provider, right? And you know, there have been some, actually Ken Wells, the group that did the Partners in Care study, mapped what it takes in certain parts of Los Angeles if you don't have a car and if you live in a somewhat depressed neighborhood, to actually get through on public transportation to try and get to a mental health care provider can take you hours. Whereas you're more likely to be able to access a primary care provider somewhere. But sometimes simply the availability of services in your environment are incredibly important.
Mm-hmm. Yeah, we have a question from the audience about statistics related to the disparities and outcomes related to Alaska Native populations. I don't know if that's something that you know. It's certainly of interest to our center as we serve Alaska. Do you know specifics about that?
I can't give you specific outcomes off the top of my head. I think the data that I'm most familiar with around, and this is only because of the kinds of studies and kinds of work that I've been involved in specifically, have to do with looking at outcomes with respect to suicide, where I think most people know that there are much greater rates of completed suicides in some Alaska Native communities. It's also not that really does vary as well when you within Alaska, right? That varies by community. So this is not, you cannot make that statement and just say that this is an effect in all communities, but that's one. The good news is that the data that I was showing you from NISDA, from SAMHSA, typically will be, they do sub-analyses by race and ethnic group. And you may have to wait for that 2019 data to be presented before you can look at some of those outcomes.
Yeah, and it's a nice segue to our subsequent webinars in this series. One it won't address Alaska Native, but we'll be hearing about a really interesting model from the Lummi Nation and the Tribal Clinic and how they've integrated a whole range of services. So we can try to collect that information and make that available and to try to address kind of the specifics related to disparities. A final question, I think we have time for one more question. On the chart, the number of youth in both white and Black were the same. Any reason why? Oh, that year, I think it referring to the trajectory of the adolescent treatment of depression. And there was one year where the graphs came together.
They came together. Yeah, that's a really good question. I'm just trying to see if I can quickly find that slide where they converged. You know, I don't have an answer to that. I do not have an answer to that. And it would be very interesting to understand, was there something different in the sampling that year? Was there something different in the way that it was measured, or was there a real change? Mm-hmm. Was there something happening that led to a change such that we saw this increase in equity? Yeah, that was, yes, I'm just looking at this now. In 2011, we see this significant increase. And the other question is, was that in relation to the Affordable Care Act, right? Mm-hmm. Because the Affordable Care Act was 2010, and there are a number of young people that may have suddenly had expanded access to care by 2011. So I think, again, one would have to parse that out to see what this looks like. Mm-hmm. But it's a really good question.
Right. And I think the data on adolescence is an interesting separate topic in and of itself, just the disparities among adolescents and just the lack of access and care for adolescents. We'll end with a really appreciate the final comment about that this presentation is an eye-opener for me, and realizing the lack of care that I received in certain healthcare facilities in Northern Virginia. And I think that's something that a lot of our workforce is experiencing, and something that, resonates as people work with clients and think about. So appreciate sharing that and thinking about how we can take the information we learned today and kind of move forward in our own practice. And I think you've given us quite a lot to think about, particularly some of the population health impacts, just what it's like when there's a police killing or some really tragic accident, and how that reverberates through a community, and how far-reaching that is, and really how we might think about that as clinicians. So I think we'll end there, and thank you again. It was a fabulous presentation. I think I had a couple of more slides just to kind of ask people to please remember to complete the evaluation and to connect with us either through our website or through social media. Reach out to us through email. And thank you very much for joining us today. We appreciate everyone's time and interest this morning. Take care. Be well.
Thank you. Thanks so much.